Okay, let's just dive right into this explainer. As a coder or biller, you already know that successfully navigating government payers is absolutely crucial to your facility's revenue cycle. It's the lifeblood of the operation, right? So today, we're acting as your expert medical billing educators to break down the highly complex and, frankly, often very strict rules surrounding Medicaid eligibility, spend-down programs, and secondary claims.
We've got a packed agenda today. We're going to follow the entire life of a Medicaid claim, starting from front desk verification and categories, all the way through to back office automated crossovers and fee limits. Let's get to it.
Section 1. Medicaid Eligibility and Categories.
So as we know, Medicaid was established to provide financial assistance for low-income individuals. It covers baseline care, things like inpatient treatments, pregnancy care, and surgical dentistry. Some branches even cover specific community or nursing home care. But here's the catch, and it's a big one. Qualification is heavily restricted by highly specific income and financial asset thresholds. A patient literally has to prove they have very limited financial resources to even be considered.
But here's the thing you really need to remember. Just demonstrating low income isn't enough on its own. CMS requires that a patient must also fall into a very strict categorical box. This means they need to meet criteria based on age, pregnancy status, a documented physical or mental disability, blindness, or legally accepted immigrant status. As a biller, you absolutely must verify this carefully. And keep an eye out for special exceptions too. For instance, nursing home residents get special consideration, and a disabled child living at home might actually qualify even if their parents make too much money to meet the standard income requirements.
Moving on to Section 2, the Medicaid Spend-Down Program.
Now, you might be wondering, what on earth happens if a patient meets those categorical requirements we just talked about, but their financial assets are just a little bit too high? Well, enter the spend-down program. Think of this as a vital financial safety net. It allows individuals to still qualify for coverage by essentially spending down their excess wealth on out-of-pocket healthcare until they hit the required threshold.
Let's walk through the exact flow of how this works in practice. Step 1, the patient exceeds the state asset limit. Step 2, they literally pay for their medical expenses out of their own pocket. Step 3, they continue doing this until their personal asset levels drop down to that required threshold limit. And finally, Step 4, the target is hit. At that exact point, Medicaid coverage officially activates and takes over.
But listen up, because here is a crucial warning for your revenue cycle. You have to understand your specific jurisdiction. While federal guidelines absolutely permit these spend-downs, individual states do not implement them identically, not even close. What works perfectly for a spend-down patient in New York might trigger an instant denial in Texas. So always check your local rules.
Section 3. Verification and Coding Rules.
When your team is submitting a claim, you must investigate your state's highly specific billing standards. Certain state carriers require distinct billing modifiers to be attached to your codes, while other states don't require them at all. You absolutely cannot use a one-size-fits-all approach here, or you're just asking for rejections. And you're going to face some unique verification hurdles with Medicaid, too. On the front end, your verification is often limited to simply confirming if the patient has active coverage and if they need a referral. But here's the kicker. A patient's spend-down status is usually completely hidden from the front desk. You literally won't know there's a spend-down requirement until the back-end review, well after the claim has been formally submitted and adjudicated. It's a hidden trap you need to watch out for. Section 4. Dual Eligibility, Automated Crossovers. Okay, let's talk about patients who have both Medicare and Medicaid. In these dual eligible cases, Medicare rules actually dictate the Medicaid regulations, and if the patient provides complete Medicare information up front, the system actually does a lot of the heavy lifting for you. Step 1, the info is captured. Step 2, the primary claim is processed directly by Medicare. And Step 3, an automated crossover routes that claim directly to Medicaid for secondary adjudication. The best part? You don't have to manually send that secondary claim. The pairs just talk to each other automatically.
Section 5. Secondary Claims Fee Limits. Now we need to discuss the non-standard secondary payer rule. This is a big one. Unlike commercial secondary payers, who might cover the remaining balance based on whatever the primary payer allowed, Medicaid is totally different. Medicaid strictly caps its reimbursement at its own established fee schedule. It does this regardless of what the primary commercial insurer allowed or paid.
Let's look at a concrete math example to really cement this concept because it trips up a lot of billers. Let's say a primary commercial contract allows $1,000 for a specific procedure, and they process it. However, your state's Medicaid fee schedule only allows $500 for that exact same code. Well, Medicaid is going to look at that and firmly cap their limit at $500. So, what happens to that remaining balance? It drops straight to zero. It is entirely written off and considered fully resolved and settled. Remember, you absolutely cannot balance bill a patient for that difference.
Section 6. Summary and next episode. We have covered some serious ground in this explainer today. We started by mapping out CMS categorical eligibility, walked step by step through the mechanics of the spend-down program, highlighted those tricky state-specific coding modifiers, and finally unpacked automated crossovers and strict secondary fee caps. Truly understanding these rules is essential to protecting your revenue cycle. Next time, we're going to explore military and veteran healthcare plans, specifically TRICARE and Champus VA. But until then, I want to leave you with a thought. How many of your facility's recent secondary claim denials could have been solved simply by double-checking your specific state's modifier rules up front? Think about it. Like, share, subscribe to Decode Healthcare with Harshal.